So we're looking at immunizations, communicable diseases, and your cardiac abnormalities and dysfunction. So it's chapter 16, 21, and then ATI 20, 35, and 36. So for the purpose of the men in nursing, we're kind of switching things. So we will be doing this first, and then we're going to be doing our pre-tests when they come in, just because off those pre-tests, that's where a lot of our content's going to come from, so I would rather them miss part of this than that.
So
Yes?
we're doing ATI chapters 20, 35,
And 36. Sorry, I can't remember. All these numbers just start running through my head. So I'm going to go ahead and hand this out to you guys. It will also be uploaded. However, you guys do not have to turn anything in for this since you guys are here. But what I will have you do is we're going to take notes on here. And you guys can work in small groups for this. If we can do groups of less than 6, you're welcome. Come on, So we're going to read through this in just a second before we get started, and then we'll answer any questions. Oh, he did. Okay. I heard that. The excitement of Kawasaki's disease.
my heart, my water.
Okay, so how this case study here works is we have like what, 8 to 10 bullets up at the top. These are the concepts that we're going to look at. So the first one is nursing interventions associated with administration of digoxin for the treatment of congestive heart failure associated with ventricular septal defect, so your VSD. Then we're going to look at the doses for digoxin for the infant diagnosed with the VSD. We're going to educate parents on the physiology of VSD. We're going to assess for the symptoms of VSD. We're going to prioritize nursing diagnosis for the infant diagnosed with VSD. We're going to implement appropriate nursing interventions for the infant having difficulty feeding due to VSD. We're going to identify the symptoms associated with congestive heart failure for an infant diagnosed with VSD. We're going to identify tests associated with diagnosing CHF for an infant already diagnosed with VSD. We're going to identify the pharmacologic treatment prescribed for the infant diagnosed with CHF and VSD. And then we're going to educate the student nurse on surgical closure of a VSD. Okay? We're focusing on VSD, however, we're throwing in CHF. So we're actually going to learn 2 of the big things that we need to know, very common, that we're going to be covering in this. So you work in a pediatric intensive care unit that has access to ancillary staff, pharmacy, diagnostics, and laboratory. You're working day shift with 4 registered nurses and 2 licensed practical nurses, so your LPNs. You are also the preceptor for a senior nursing student who is currently shadowing you on the unit. The licensed practical nurses provide supportive care to all of the patients and assist the staff nurses. And you are assigned to care for the next new admission. So we're getting our admission. Christina Adams is a 1-month-old infant brought into the emergency department by her mother due to poor feeding. What else do we call poor feeding? It can become failure to thrive. Good. Christina was born at 32 weeks gestation and was just discharged from the hospital 3 days ago for the first time since birth, weighing 4 pounds, 10 ounces, and was feeding well. Christina's mother reports that Christina had only 1 wet diaper in the last 6 hours. She further reports that Christina sleeps most of the time and while awake seems very sluggish, in her term sluggish. Before starting the case, we're going to review the electronic health record for all the patient information. So her name is Christina Adams. She's 1 month old, a female. She's Caucasian. Her height is 48.3 centimeters and her weight is 2.07 kilograms. She has no known allergies. Her medical surgical history, she was premature infant born at 32 weeks gestation, weighing 3 pounds, 7 ounces, and 17 inches long. So she's had some growth. She was in the NICU for approximately 25 days and discharged at 4 pounds, 10 ounces, and 19 inches long. Adjusted age 36 weeks plus 2 days. Mother reports that infant had been bottle feeding well but began exhibiting disinterest in feeding, poor feeding, and sleeping more than usual. Social history. 1-month-old Caucasian female, recently discharged home with biological mother and father. Mother is 42 years old and father is 48 years old. Christina is mother's second pregnancy and birth. However, the first baby was stillborn. Lives with mother and father. Your first order, admit to pediatric intensive care unit. Admitting diagnosis, ventricular septal defect, VSD. Diet, as tolerated, provide formula that is 24 calories per ounce. Order 2, daily weights. Order 3, INO. Our loading dose of meds is digoxin 20 micrograms orally now, then digoxin 10 micrograms orally 8 hours after the first dose, then digoxin 10 micrograms orally 16 hours after the first dose. After the loading dose is completed, digoxin 4.86 micrograms orally twice daily, and a KCl supplement 2 milliequivalents orally twice daily, and this is your EKG reading. So you've got a little strip on here, okay? Your temperature is 99.8, your pulse is 120, your respiratory rate is 50, your BP is 82 over 50, and an oxygen saturation of 92%. So, our focused assessment is completed. We have no known drug allergies, no known food allergies, and no known latex allergy. The head is found to be normal cephalic. The eyes, there's normal extraocular muscles, EOM bilaterally, and pupils equal round, reactive to light. So PERRL. Remember, with an infant, we can't really do the A. Ears are patent bilaterally, the tympanic membranes intact bilaterally, no signs of inner, middle, or outer ear infection. Nose, clear, no drainage bilaterally, nares patent bilaterally. Mouth, no teeth present, mucous membranes moist but pale. Respiratory, 50 breaths per minute. Breath sounds equal bilaterally with no adventitious breath sounds. Apical pulse 120 beats per minute and a murmur identified. And GI bowel sounds present in all 4 quadrants and within normal limits. Questions on our scenario. So what we're going to do first is we're going to go into our little groups. Does everybody have a group? Do you want to squeeze in and maybe, if you guys want to come and work the 4 of you guys? And then you guys are a little bit big, but are you guys okay? You guys work well together? And then do you want to turn around, Taryn, and work with the girls? Perfect. And then you guys, Paola, if you want to squeeze in with them, please. And then you guys are going to work as 4 over here. Are you guys okay as 2? Yeah. Okay. Okay, so I'm going to give you guys about 15, 20, actually we'll give you till 11:30, and then we're going to start talking about this, okay? I'm sorry?
We're answering the bulleted questions.
The bulleted questions, yes. So you guys are going to be going through these bulleted questions at the top, the 10 bulleted questions. So what are nursing interventions associated with the administration of digoxin for the treatment of congestive heart failure associated with ventricular septal defect? Yes? Apical heart rate for 1 full minute. On an infant, what does our heart rate need to be greater than? 90. On a child, what does it need to be greater than? 70. And an adult? 60. Who cares about adults at this point, right?
They'll be fine.
They're adults. I'm just kidding, but those are very important. So we want to remember the 62. So 60 for adults, 70 for your children, 90 for your infants. So we've got a 1-month-old. So which one are we looking at? 90. Good. So it's talking about calculating the appropriate dose of digoxin for the infant diagnosed with VSD. I know we said don't focus on the numbers so much. Did anybody get the calculation for it?
She did.
In a 24-hour period.
0.8 to 2 micrograms per liter.
0.8 to 2.0 micrograms per liter. That's I would say that's a digoxin level. Per liter, that's not a dose.
It's pretty, it sounds right. They were even differentiating between like 1 month old and if they were premature. And
Yeah.
use the-
What did you get for yours?
41.4, 52.1.
Is the daily dose. Daily dose, yes.
And
Yes.
the maintenance would be 4.86.
That's what this one's ordered, yes. That one's ordered for this one.
It would be 10.35 and 16.5, sorry.
Okay, I'm like, that's what's ordered for this
Yeah.
guy. Yeah, so when you look at this one, did you feel confident with this amount that you were giving?
Yeah, because it's less, right?
Good, it is less than that. Okay, so if we're teaching parents on the physiology of VSD, what do we want to tell them? What's the problem? Yes, Brenda.
There's a hole in the septum between the right and left ventricle.
Hole in the septum between the right and left ventricle. Remember, the ventricle's on the bottom side of the part of the heart. That's where our strong part is, right? So what's happening here? Increased pulmonary blood flow from the shunting, back and forth. So it's putting all that up there. And if we have increased pulmonary blood flow, what can it lead to? It can go to heart failure and the CHF, the congestive heart failure, because we're going to start filling things up. And remember, when we're watching for that, we're listening to our lung sounds, and then we're watching for edema. So we could even see periorbital edema in the hands, in the feet, all over. What else do we want to educate the parents on? What'd you say? What about feeding? How's this kid going to do with feeding? Not very well. They're going to tire easy, right? They're going to get really tired. Sometimes these are our main symptoms that we see coming, is these kids are tired. So what kind of things can we do for feeding for this kid? Some nipple gavage or an NG tube. So maybe a cyst, so maybe every other feeding. Try and figure out the best way to manage this, just to make sure we're getting our increased calories. And we want 24 calories per ounce. So we want to make sure that we bump those up a little bit for these kids. Anything else we want to teach the parents on? What about color? Do we anticipate color changes? Yes, these babies could have pale or they could have some cyanosis because you got mixing of your blood because that's open, right? So what are my symptoms of VSD then? What was it? A loud, harsh murmur. Fatigue. We could have some tachycardia. What else? What'd you say? Over here. Hypertrophy of the right and left ventricles because it's affecting both of those. Good. Any other symptoms? Any other main things? Poor growth. Absolutely. Did you say something back there, Alex? Yeah, you could develop JVD.
Shortness of breath.
They could have shortness of breath. The infant probably can't tell us they're short of breath. So what would we see in the infant? They could be tachypnic. They could have some retractions, things like that. Absolutely. So what kind of nursing diagnoses are we going to look for this kid? Poor gas exchange. What else? Decreased cardiac output. Excellent. What else? Excessive fluid volume. I heard another one.
Failure to thrive.
Failure to thrive. So our nutrition is going to be high or low? Low. We want to give them what kind of calories?
24.
We want high calories. Good. I knew what you were saying. Gotcha. You're like, hi, we need to feed them, feed them. So it's just hard because they don't eat very well. They're tired. They get really tired, and feeding is like a chore for them. So we already talked about nursing interventions for them having trouble feeding. Sorry, I jumped ahead on you. I got excited. So if we go into congestive heart failure with our VSD, what are our symptoms going to be? Crackles. You could get hepatomegaly. What else? Periorbital edema. Decreased urinary output from the poor cardiac perfusion. Good. Good. You could get lower respiratory tract infections. Why? Pulmonary congestion. You got a backup. You got some fluid hanging out in there. Anytime you got fluid hanging out, you put that risk of infection. So we really want to watch for that. With a kid with CHF, what tests are associated with diagnosing the CHF? Chest X-ray, ECG. You can do an echo. On a chest X-ray, what could you see? You could see infiltrates in the lungs and in the heart. Would you say cardiac hypertrophy? Okay, so then that right and left ventricles. What else can it lead to? If they start hypertrophying, it starts getting bigger. What's that called? Cardiomegaly. Good. Good. All right, so what's some of the pharmacologic treatment for an infant with CHF and VSD? Diuretics. What else?
ACE inhibitors.
ACE inhibitors. Digoxin. Excellent. What about oxygen? We want to give these kiddos oxygen, especially if their pulse ox is low. And what was her pulse ox? Was it 92? So it's okay, but would we want to boost her up? Because if we can decrease some of the work of just breathing, we can kind of conserve some of their energy. So anything to conserve energy for these kids is a great idea. Now, it's talking about the surgical closure of VSD. If they are mild symptoms, when do we want to go in and surgically close the VSD if it doesn't close on its own? After 1 year. So we give it 1 full year. If it closes on its own, we just monitor the baby, make sure everything's good, watch the growth patterns, watch the eating. If they have CHF or are very sick, when do we want to close it? Less than 6 months. Good. So questions on this? Does that kind of help put this all in perspective? Okay. So when we're looking at a VSD and the baby comes out, do we always see the symptoms right away?
No.
When do we tend to see them?
Can they go home?
When they go home or within the first couple of months. So sometimes we don't manifest it because the kid's just kind of tolerating it. Now, we talked about the loud, harsh murmur. One thing to keep in mind, as those murmurs close, sometimes you hear it a little, or as the defect closes, sometimes you hear the murmur a little bit louder because there's more turbulence as the hole gets smaller and smaller. So we always, listen, oh, look, it's getting louder. Sometimes it's just closing. So, questions on this at all? Did this put it in perspective?
Yes.
Good. You know that that's going to be, it is one of the more common things that we see cardiac-wise. Do you see a lot of them?
Yep.
So we do want to watch for those. So do you want to add anything clinically for the VSDs? I think we covered all?
Yeah.
Alrighty. Other questions on it? Because I'm going to give you guys a little break. Go. Okay.